Good morning. Good morning. Welcome, everyone, to the Joint Commission on Healthcare. Rodney Willett here this morning as chair and MC. We've got some great presentations, one vote to take today, but I'm so excited to have so many folks with us. With that, I'm going to ask Agnes to call the roll.
Thank you, Mr. Chair. Good morning, JCHC members. Delegate Willett.
Here.
Senator Hashmi.
Here.
Delegate Ennis. Senator Favola. Here. Delegate Hayes. Senator Head. Delegate Hodges.
Here.
Delegate Hope. Senator Locke.
Here.
Senator Lucas.
Here.
Delegate Orrock. Senator Pekarsky.
Here.
Senator Pillion.
I am here online.
Delegate Price.
Here.
Delegate Reeser.
Here.
Delegate Sickles.
Present.
Senator Suederlein.
Yes.
Delegate Waxman.
Here.
Mr. Chair, we have a quorum.
Okay, Agnes, thank you so much. And then we're going to go right to Sarah Stanton to have us to walk through the agenda.
Mine's on. Okay. Good morning. I feel like I was just here. So today's agenda, we have several items for you. We'll start with, today's agenda will include an overview of the public comment received on our study that was briefed at the last meeting on policy solutions to the Commonwealth's fentanyl crisis. After that, you will have the opportunity to vote on the policy options presented. We will then move into a staff briefing on strategies to address transportation-related barriers to healthcare. As a reminder, today's briefing will include some background information and explanation of the findings and presentation of the policy options. You will have the opportunity to vote on those policy options at our next meeting after we've had the opportunity to collect, receive, and present to you the public comment that we receive. Then finally, I will give you a quick overview of the projects that were selected for our 2026 work plan at the end of the meeting. Before we move into the presentations, though, just a quick reminder of our voting process for you. As I reported, voting on our policy options generally occurs at the meeting after the meeting at which the briefing occurs to allow that time for the members to consider the information that's presented, read the report, and then also to allow the public time to provide a written comment and for us to give those to you. So at the meeting following that presentation, which is today's meeting, you will have the opportunity to vote on the policy options. What will happen is that our analyst will provide a brief overview of the study findings and the policy options and the public comment received. You've also, members of the commission, received a packet that does include all of the comments we received. After we've walked through that information, the chair may wish to open the floor for discussion, questions, and motions from JCHC members. We will need a motion and a vote if you wish to move one of the options to a recommendation. You can also amend the options before you adopt them if you'd like to do so, or you may add new policy options that are not included in the list that we provided. Adopting a recommendation does require a majority vote of the members present. It also requires that at least half of the House members present vote for it and at least half of the Senate members vote for it. So we'll keep track of that as we have voting if we need to look at those ratios. The chair may wish to solicit volunteers to patron legislation or budget amendments that implement these recommendations. We would love it if we knew who the patrons would be when we leave the meeting today. If we don't have patrons, we will happily follow up to secure patrons. Once we know who those patrons are, we will work with you in your office and DLS and the Money Committee staff to prepare draft language for any legislative recommendations or budget amendments. And we are available to provide support during the General Assembly session with information, talking points, or whatever you may need. So if there are questions, I'm happy to answer them. Otherwise, we can move into our first presentation of the morning.
I think we're good. Thanks,
Fantastic. Okay, then Jen, I'll turn it over to you.
All right, good morning, Mr. Chair, members of the commission. Last month, I provided a brief on the findings from our study on policy solutions to the Commonwealth's fentanyl crisis. So today, I will review the study's policy options and public comments we received on those options for your consideration as we move into voting. As a reminder, the study resolution directed the JCHC to study the rise in fentanyl prevalence and overdoses, the impact of fentanyl on Virginians and the healthcare system, and the fentanyl crisis in the context of other recent drug trends, and to make policy recommendations to reduce fentanyl prevalence and overdoses in Virginia. Very briefly, our study found that illicit fentanyl is highly addictive, readily available, and deadly, and that the impact of this drug on the Commonwealth has changed over time. Virginia is successfully implementing multiple evidence-based strategies to address illicit fentanyl. The study identified 2 areas for further focus: taking additional steps to enhance ongoing efforts, and expanding services to close gaps for high-need populations, including pregnant women and individuals who are incarcerated. To maintain progress on opioid misuse and illicit use in Virginia, the first policy option suggests JCHC could designate VDH as the lead agency for comprehensive opioid response in the Commonwealth and direct relevant state agencies to work with VDH to create, implement, and monitor a statewide strategic plan for opioid response. This option could also include a budget amendment for VDH to begin their statewide strategic planning process with a comprehensive needs assessment or evaluation of existing efforts. The Virginia Association of Regional Jails provided public comment supporting this policy option. The next 4 policy options, options 2 through 5, relate to the availability of opioid antagonists such as naloxone to reverse overdoses from opioids. Option 2 suggests JCHC could appropriate funding each fiscal year to VDH to maintain the agency's opioid antagonist distribution program. VDH recently submitted a decision package for consideration in the governor's introduced budget of $5.1 million per year beginning in fiscal year 28 to maintain the program. The Virginia Association of Regional Jails provided public comment supporting this policy option. Policy option 3 suggests the JCHC could direct VDH to develop a methodology to estimate annual naloxone distribution program costs and to report annually on such estimates. VDH is already required to submit quarterly reports on the quantity, formulation, and dosage of opioid antagonist kits distributed, but this does not include estimates of future program funding. This would help the General Assembly and members of the public better understand how the resources needed for the program align with the program goals as the landscape of opioid overdoses continues to change in Virginia. The Virginia Association of Regional Jails also provided public comments supporting this policy option. Policy option 4 would permit flexibility in the use of available program funding by removing the requirement that VDH dedicate $1 million of its naloxone distribution program budget to the purchase of and distribution of 8 milligram naloxone nasal spray. This option would not prohibit the purchase and distribution of the 8 milligram spray, but would allow program funding to be used more flexibly to purchase opioid antagonist products. We did not receive any public comment on this option. Policy option 5 suggests health insurance providers cover naloxone or other opioid antagonists without prior authorization, cost sharing, or other requirements. This could eliminate barriers to accessing opioid antagonists through insurance coverage. This policy option would likely require review by the Virginia Health Insurance Reform Commission. One individual supported this policy option through public comment, and the Virginia Association of Health Plans recommended an amendment, namely that the language for this legislation require no-cost coverage to be limited to at least one product instead of all opioid antagonist products. Moving on to policy options that support treatment and recovery. For policy option 6, the JCHC could direct the boards of dentistry and medicine to amend regulations to clarify that patients' participation in counseling is not required for receipt of medications for opioid use disorder. This option is intended to clarify that medications should be made available to patients even if the patient refuses counseling or counseling is not available. This change would also bring Virginia into alignment with federal regulation, which was updated in 2024, that state counseling should be clinically necessary and mutually agreed upon, and that patient refusal of counseling shall not preclude them from receiving medications for opioid use disorder. We received support for this policy option from one individual and from the Virginia Association of Community Services Boards. Policy option 7 addresses barriers within VDH and the Department of Corrections to hire peer recovery specialists. This policy option suggests Section 1 bills that direct VDH and DOC to develop agency guidelines for hiring peer recovery specialists with previous criminal convictions for compensated employment. These guidelines would be intended to clarify requirements for employment in specific programs at these agencies. And at a minimum, these guidelines should afford similar opportunities for employment at VDH and Department of Corrections as peer recovery specialists employed through DBHDS. We did not receive any public comments on this option. Policy option 8 addresses barriers to treatment for pregnant women through expansion of Project Link, a DBHDS initiative that provides intensive case management, home visiting, and child care and transportation support for women seeking treatment. The policy option suggests providing one-time general funds to DBHDS to cover the cost of establishing 3 additional Project Link programs at CSBs in the Commonwealth. The funding would be used to establish programs, which are then sustained through a mix of federal funding, Medicaid reimbursement, and local funds. Adding an additional 3 sites in areas of need would bring the total number of Project Link programs in the Commonwealth to 17. This policy option receives support from the Virginia Association of Community Services Boards, the Virginia Association of Counties, and the Virginia Association of Regional Jails. The last 3 policy options, options 9 through 11, address treatment and transition services in local and regional jails. Starting with option 9, which suggests that JCHC could direct a VDH to develop and implement a plan to expand workforce incentive programs to healthcare workers in local and regional jails. Currently, medical and behavioral health personnel working in local and regional jails are only eligible for 1 state-administered loan repayment program. This policy option provides VDH flexibility to determine the most efficient and effective means to extend healthcare workforce incentive programs to personnel working in local and regional jails. Policy option 9 receives support from the Virginia Association of Counties and the Virginia Association of Regional Jails. Options 10 and 11 are intended to increase state resources invested in grant programs to support treatment and transition services in local and regional jails, and to propose additional flexibility in grantee selection to expand services in more localities. Expansion of grantee sites beyond the initial cohort is currently limited by budget language. Policy option 10 recommends an expansion of the jail mental health pilot program to include increasing funding for the program, permitting the selection of additional grantees, and establishing time limits for the duration of grant awards to ensure expansion in the future. This policy option receives support from the Virginia Association of Counties and the Virginia Association of Regional Jails, with the caveat that existing allocations for currently funded programs should be preserved. Policy option 11 recommends sunsetting the Model Addiction Recovery Program, which receives about $154,000 in general funds per year, in favor of expanding the Virginia Opioid Use Reduction and Jail-Based Substance Use Disorder Treatment and Transition Program, or the JSUT program. This program received $2 million in state funds from in FY24 from the Commonwealth Opioid Abatement and Remediation Fund, but with no additional appropriations. This policy option also recommends providing technical assistance to current grantees of the Model Addiction Recovery Program so that they can apply for the JSUT program. This policy option receives support from the Virginia Association of Counties, again with the caveat that currently funded programs should be held harmless, and an amendment from the Virginia Association of Regional Jails, suggesting that the funds from the Model Addiction Recovery Program could be moved to the Jail Mental Health Pilot Program, which is option 10, instead to cover agency administrative costs for that program. They also suggested an alternative to either policy option to increase funding to the Compensation Board for behavioral health staff. And Mr. Chair, I'm happy to address any questions at this time.
And thank you, thank you so much. And again, we should tell you that was an excellent report on a super critical issue. And even with all the progress that's been made on getting the overdose deaths down, there's still an addiction crisis and a lot of people suffering out there. So I really appreciate that. Appreciate the recommendations here. So with that, we actually have a lot of options here to consider. I'd say about, by count, at least 2/3 of those are related to budget amendments. The rest would be code changes. Some are Section 1 bill recommendations. Always trying to get us here. This is a lot to consider. We can certainly, we have a couple options. We can go through these individually to look and decide whether we want to approve them. We could also do it as a block and then come back and see who is interested in carrying one or more of these. So I'm certainly open to suggestions. And again, these are all coming right out of the reports. Yes, Senator Favola.
Thank you, Mr. Chairman. I had a quick question. There really, at least I have not found any suggested budget amounts associated with the option. So I don't believe that any number would play here. I think there probably is sort of a baseline number that would be needed for each option. So my question is, if we approve the options, then there would be an accompanying budget amendment that staff work on, finance staff work on. Is that the expectation?
Mr. Chair, Senator Favola, I do have some budget amounts for the policy options. I can run through those if you'd like. Again, they're just sort of guidelines that we would continue to refine.
You've got a few appropriators up here who are interested in that. So,
Well,
yes.
I was about to ask a question. I looked over on Senator Locke's paper, and we both have the same question, and especially for policy option number 3. I'm concerned about that cost.
Okay. Jim, that's a great suggestion. As much as you know, let's walk through those. I think I do see a couple of numbers, but I think there were some definite questions there. So let's walk through that, particularly number 3.
Mr. Chair.
Yes, Senator Pillion.
Hey, and some of these are not coming out of, these are also coming out of the core fund, right? The Opioid Abatement Authority money.
Yes, Mr. Chair.
Is that correct?
Yes, Mr. Chair. Some of these, and Senator Pillion, some of these are currently funded out of the core fund and could be expanded from the core fund.
Right, and I would think that when you go through those items, Chairman Lucas would probably appreciate knowing which ones that you anticipate coming out of the budget and which ones coming directly out of the core fund through.
Absolutely.
Right, Chairman Lucas?
That's correct. Thank you.
Okay, that's good.
All right. Yes, ma'am.
And Senator Locke.
For those organizations or individuals that proposed amendments, do we have those amendments?
Mr. Chair, Senator Locke, the amendments are within the public comments. I can summarize them if you'd like on each option again, if that's helpful.
Because I think I heard one of those, but not the other. So why don't we do this? Let's go through each each of these that has a budget impact.
Sure.
Or requires a budget amendment, and then and I do see 2 that have that have amendments suggested. And let's make sure we know what those are, and whether we want to incorporate that.
Sure, absolutely. So, Mr. Chair, option 1 it could be legislation only, so no budget necessary. However, VDH was interested potentially in funding for a needs assessment and evaluation. If that were the case, it would be $150,000 1 year, and that would be out of the general fund. Option 2 is the expansion of VDH's opioid antagonist program. They have requested in their agency documentation $5.1 million beginning in fiscal year 28, and that is from the core fund. Option 3, we believe, could be a language-only budget amendment. A lot of this work VDH already does to submit their budget request to the governor, and so it would just be the process of making that more formal and more public. Option 4 is a language-only budget amendment with no change in funding. Option 5 would, in the short term, be language only. Upon review by HERC, there may be a fiscal impact, but that's not something that we know quite yet. Option 6 is language only, no budget impact. Option 7, also language only, no budget impact. Option 8 is for 1.5 million, and that is out of the general fund. Option 9 is language only. Option 10, you have some flexibility here. The current funding for this is $2 million per fiscal year, and that does come out of the general fund. So you could, if you chose to expand funds, let's say by adding an additional 1 million, that would be approximately 3 additional grantees. If we went up to 2 million additional dollars, so 4 million total, you're talking about 5 grantees. So there's some flexibility there. And then for option 11, the addiction recovery program is currently $154,000 per year out of general funds. The JSUT program was a 2 million one-time appropriation out of the core funds. So again, some flexibility there in terms of expansion. If we added approximately 1 million from the core fund, you might get an additional 6 grantees. Up to 2 million in the core fund is potentially 12 grantees. And then, Mr. Chair, the amendments that I mentioned, sorry, I didn't go through those in the moment. So for option, actually, let me go back and make sure that I have them here. I
Mr.
believe,
Chair, while she's looking for that,
Yep.
if I could ask,
Yes,
have
please.
we considered some of these, she's stating that, are funding through the general fund. Have we considered that some that potentially she's assuming would be funded through the general fund could in fact, or in turn be funded through the core fund? Have they considered that? Just because I know the budget is going to be significantly tight this year from what we're seeing, and if the core fund could provide an opportunity to fund some of these initiatives without being in the general fund, again, I know that Chairman Lucas would probably appreciate that.
Mr. Chair, Senator Pillion, that's certainly something that we could consider as we further develop these.
No, great.
Thank you.
Yeah, great question, suggestion there.
Mr. Chairman,
Yes, Delegate
I
Sickles.
just wanted to ask the commission here whether, but if you say we want to introduce a budget amendment, that doesn't have a specific number to it, and we consider all budget amendments, and it would be, if we supported that, people would know that goes up against every other priority that the state might have, versus policy number 8, where it says 1.5 million, which is pretty specific. And that I would feel uncomfortable, coming up with voting on a specific amount right here out of context for all the other pressures we're going to have, as the senator from Abington noted. Thank you.
Mr. Chair.
Delegate Price.
Yeah, I think my question, one of my questions is along the same line, and I know that you were pulling up the amendments, but before we get off the money portion, do you, Mr. Chair, see our job here as voting on the concept of the policy suggestion, knowing that the budget conversations, A, we don't have the full picture today, B, those conversations happen on 2 different floors that are not the second, but that it would be the job of the Commission on Healthcare to talk about what we want to see, knowing that it would be if we have the money, or do we need to, in your eyes, because there's so many appropriators on this commission, do we need to have that money conversation today? Because I think with respect to what Chair Sickles said, option 10, option 11, we have the current amount, but if we wanted to expand, blah, blah, blah. But we could just say, at least, we don't want it cut from the 2 million as much as possible, or something like that? Or do you think that we need to come up with those exact numbers today?
That's an excellent question. I'm going to bounce that to Sarah just for precedent in terms of what we normally have done there.
Mr. Chair, happy to attempt to answer that question. When we develop our policy options, we do try to keep in mind the context in which we are proposing them, but we also try to balance that against the charge we were given, which is to identify policy solutions that could address a policy problem. So these are options that include funding. The policy idea is intended to address a specific problem that we identified in our work. We are well aware that there are competing priorities that all of our members face and that appropriators must address as they make decisions about what to fund. But based on the work we've done, the evidence supports these concepts as viable solutions to the problem identified. We have tried to give you specific information about the cost and what you could do with that, fully understanding that that may change as you move these through the legislative process and have to navigate those different priorities that confront you.
With that, Mr. Chair, and I'm sorry, my request to speak button is not working, but I'm not being rude, y'all. But with that in mind, I think I would then have one other question and then hope that we would save the, maybe, blah, 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 understanding the situation, but I would hate for us, because we have so many folks that know the budget process, for us to preempt any good ideas today based off what we think might be happening in January, when we could have that conversation in January once we know a more full picture. And if that is the case, then I would ask if there are any competing or conflicting policy solutions, or could all of these 11 stand together should there be money for said proposals?
Mr. Chair, Delegate Price, thank you for the question. These policy options stand by themselves. So they could be all implemented pending, obviously, resource constraints, or you could select from a number of them.
Yeah, I appreciate the questions and comments, and Sarah, thanks also for the background on that, because my feeling was, yes, we're looking at this at a policy level. And if we think these are good policies that in some cases need to become laws, some cases need a budget amendment, we can decide to endorse or not endorse that. Obviously, we're very concerned about budget impacts, and at least at this point, we have sort of an order of magnitude as to, you talk about $100,000 or $1 million, but of course, a lot of that is still TBD, so it would be up to me or someone else who may take on one of these budget amendments then to work with staff as we do to get a more specific proposal in there. And yes, absolutely, lots of competing proposals out there. Good, but no, that's very helpful. I was going to pivot for a second from the money back to, yeah, exactly, back to the amendments, exactly. See, I read my mind. Thank you, Delegate Price.
Sure. So, Mr. Chair, two options were, we received amendments or possible amendments in public comment. The first of those was option 5. So that's suggesting health insurance provide coverage. The Virginia Association of Health Plans recommended that the language of this legislation require no-cost coverage to be limited to at least one product instead of all opioid antagonist products. So that was the change that was recommended there. And then for policy option 11, the Virginia Association of Regional Jails suggested an amendment that the funds from the Model Addiction Recovery Program, which are general funds, actually be moved over to the the Jail Mental Health Pilot Program, which is also general funded, so that the JSUT program remain core funded. But as Senator Pillion mentioned, some of that could still be flexible. So those were the two amendments.
Mr. Chairman.
Yes, Senator Favola.
I would move that we adopt the amendment to option 5, which the insurance industry is saying for them to keep it at a no cost to a premium increase, they could only cover one FDA-approved over-the-counter opioid antagonist. So I would move that we adopt that amendment to option 5.
Second.
We have a second. Motion second to amend option 5. Any discussion on that? Yes, go ahead.
This is standard policy, isn't it? We have a formulary for our Medicaid members to follow. So it's, I mean, I'm supporting your amendment.
Oh.
Yeah, this is current. We do this for everything else.
This is correct.
Yeah,
Right. That was your question, yes.
yeah.
Mr. Chair?
Yes, go ahead.
Just a point of clarification. Does the amendment limit it to one or allow them to limit it to one?
I will ask staff to interpret that since it was your suggestion.
Mr. Chair, Delegate Waxman, the language was at least one, so they could expand beyond that.
Thank you.
Mm-hmm.
So just to be clear, Mr. Chairman?
Go ahead. Senator.
Just to be clear, the insuree, if you are, would be able to, with a doctor's prescription, or if not over the counter, select the one that would be covered. So there would be some consumer choice contained in that amendment. Is that correct?
Mr. Chair, Senator Vola, yes.
Good questions, all good questions. Any other discussion? We could, just to get this in the proper posture, we've had a motion and a second and had discussion. All in favor of that amendment, say aye.
Aye.
Any opposed? Okay, so we will adopt that amendment to option 5. And then Jen, I think you had one more for us.
Yes, Mr. Chair. So option 11, this is the option to sunset the Model Addiction Recovery Program, and the amendment is concerning where those funds would go. The current policy option suggests that they roll into the JSUT fund, but the JSUT fund is core funded. And so the amendment from the Virginia Association of Regional Jails is that those funds from the Model Addiction Recovery Program move over to the Jail Mental Health Pilot Program, which is option 10. Both of those are general funds. The idea being that the funding from the Model Addiction Recovery Program would cover the administrative costs of the Jail Mental Health Pilot Program, therefore allowing more money to go to grantees.
Thank you, got it now. I missed that the first time, that makes sense.
Question, Mr. Chairman?
Yes, Senator Vola.
Do you know this program's up and running? I remember we funded it in 2024. How many local jails are actually benefiting from the opioid abatement programs that this is intended to fund?
Yes, Mr. Chair, Senator Vola, the JSUT program has currently funded 15 grantees in 2 separate cohorts.
Do we have any, Mr. Chairman, follow up? Do we have any information on whether the treatment programs that individuals received in jail were actually effective, and whether the transition plans that were part of the grant program, whether the transition plans were effective in enabling folks to actually stay clean when they exited jail?
Mr. Chair, Senator Vola, this program is relatively new. The first grantees received funding in January of this year, and the second cohort received funding in July. So we don't have that information yet, although reporting requirements are required for the program. However, what I can tell you is that the guidelines for this program require evidence-based treatment and transition services. And so barring other issues, we would expect them to be effective in these settings.
Well, Mr. Chairman, I believe I'll go ahead and move the amendment because, as I understand your explanation, more dollars would in fact be available for actual grant programs.
Yes, ma'am.
Because you're changing the funding of the administrative coverage.
Mr. Chair?
We've got a motion in a second there. Delegate Price.
I just had a question with and this is not to suggest that this is what we should do, but should option 10 and 11 then be tied together? So, or is there some way that we could just make sure that if cuts are to be made, that we're not cutting a program that we're moving funds to, in a sense that if one person is carrying one of the budget amendments, that we know that this other thing has to exist in order for money to move from one thing to the other.
Mr. Chair, Delegate Price, I think your point is well taken. I think the implementation of what these will actually look like through session may change, and it may be that the most efficient way is to actually combine these into one budget amendment so that we shift funds appropriately or expand funds as needed without necessarily cutting funds for any single program.
That's helpful. So we could still go forward with the we need to vote on it, but with the amended version 11. But it's a practical matter. We may actually combine things when we get to the budget process. Okay.
Yes, Mr.
Let's come back to the amendment. Then we've got a motion and a second. Any other questions or discussion on that? Hearing no questions. All in favor of that amendment, say aye. Aye. Any opposed? Okay. So we'll take that one as well. So, options for the options, we can take these as a block and vote.
Mr. Chair.
You want to vote? Yes.
I thought you might be going in that direction. So before we think about the block, in order to address Chairman Sickles' concerns, is it possible for us to make an amendment to option 8 to strike for $1.5 million and just leave it as a budget amendment for that amount to be determined later so that we feel comfortable voting on the concept, but not necessarily the exact amount of funds, but all of us remembering that that's what it needs to be in order to be, at the full idea level.
I will second that motion, Mr. Chairman.
Yeah, thank you. That's great, Senator Favola. Any further comments or discussion? I appreciate you flagging that.
Mr. Chairman, I just want to note that almost any number would play here. The 1.5 million actually was just tied to an expansion in certain areas. We could target the areas. We could come up with another number. So that's my rationale for seconding the motion.
No, good point. Any other discussion on that amendment? All in favor of that amendment, say aye. Aye. Any opposed? No, okay. So we've also amended that one. Good catch on that. So back to the broader question. We can take these as a block. If there are other questions, we can certainly take these individually. And one way or the other, we do need to come back and look at who's interested in carrying what. So I am open to a motion to consider it a block, or we can go individually. Okay, so we'll go. So we have a motion to approve options 1 through 11 as amended, in the three that are amended. All in favor, say aye. Aye. Any opposed? Good. Okay, so we've adopted the 11. Now, last task on this part of the meeting is to. We love volunteers for these initiatives, and the staff will keep track of this, but we can literally just go 1 through 11 there. And if you volunteer early, we have the finance chair said they'll approve any money you want. No, that's not.
Mr. Chair.
Yeah.
Can we talk,
okay.
Mr. Chairman?
Delegate Price.
Yes, I would like to volunteer Senator Pillion for option 7, since he volunteered me last meeting. But actually, I do think that.
Oh, shoot.
Which is even better. No, I do think that the two of us could continue our work on barrier crimes, especially as it pertains to peer recovery specialists with option 7.
And I really appreciate that. I was just on a panel with the recovery homes, a couple of my colleagues, and we made progress, thanks to your good work and Senator Pillion's good work, but there is more to be done. That's what I'm hearing, so I appreciate that. So we're going to give that one.
I will volunteer, Mr. Chairman, I'll volunteer for option 5.
Okay. Let's see there. Okay, Barbara there. Yes, you're good.
Mr. Chair, while members are considering which options they might be interested in carrying, I will note that all policy options will be pre-filed, and I believe under the Senate rules, commission bills will not count towards limits.
Won't count towards one limit. We have another limit on commission bills. We have 5
Do you have, oh, I'm sorry. I was
commission
wrong on
bills.
that.
So
They're
this
all
is eating up
pre-filed.
20, I just want you to know, 20% of my
Okay, on your commission option,
commission
okay.
bills.
Sorry, that is correct. I'm sorry, I've got to update my notes. You do have a 5-bill limit. But for the
reached
House,
my
they
limit,
are all
Mr. Chairman.
pre-filed.
Okay, okay. You're sensitive to those limits. Go ahead.
Number 7 is price of Pillion and
Senator Hushman.
Thank you, Mr. Chair. Continuing the Pillion train here, I would love to volunteer, since he's not here, option 6 to Senator Pillion, since he is our resident dentist as well.
Boy,
I think that's good.
now, this will be the last time he ever leaves a meeting early with our group. We've got Delegate Reeser on the line.
You are being volunteered.
I'm sorry, the mute button's a little slow to respond. I'm happy to take option number 5. That is, if someone else would like to make the motion who's attending in person.
Okay, great. So that's for Tuesday. Okay, got it. Okay. Yes, we've got Delegate Sickles.
I can do 8 and 9.
Okay.
Okay.
8 and 9
Mr. Chair,
Yes.
I'll be glad to do 4 since it deals with the drug.
Okay. That's Delegate Waxman on option 4.
Delegate Wax, Mr. McFarland.
Mr. Chairman,
Yes, Senator Kukowski.
I am happy to do number 1, and if nobody else does, number 5.
I think we're good. You said I think we're good on 5.
Okay, I'll do 1.
Okay.
Sickles, did you take 4 and 5?
I just took 8 and 9.
8 and 9.
8 and 9. So by my count, we.
You can have any of them. Anybody else wants 8 and 9?
I think we have, just to recap, we have open options 2, 3, 10, and 11. Any takers? Oh, did I miss one? I think we got 7C, Delegate Price and Senator Pillion. Thank you.
Mr. Chairman?
Yes.
Like you said you had 3.
Yeah, we've got 2 and 3, and then 10 and 11.
Take 3.
Okay.
The same person might need to do 10 and 11, since it might.
Well, that's a
be
good point. That's a good point. So we, Delegate Hodges on option 3, and then 10, 11. I'm glad to take those two together.
10 and 11?
Yes, I'll do that. Okay. And we are down to. Yeah. Boy, I love this play. This is awesome. We can get a lot of work done in this. Where's this EDH come with today? If there are no takers on that one, we could certainly, because we do have several members not present, as we noted, so maybe we flag that to see if any of those are interested. Because maybe they actually are dying to have one of these, and they just aren't here. Right. So we may have just done them a favor. Okay. Yes, sir. Mr. Sick.
Happy to be assigned anything.
Okay. I think we're good. I think we've got, because we got you.
Okay.
on 8 and 9. And yeah, and I'm going to do 10 and 11 together. Yeah, I'll do those two. And Sarah, we could certainly default to Delegate Sickles or myself on option 2, but I'd say throw that one to anyone who's not present. And if they're so inclined, and that will cover.
Mr. Chair, what we'll do is after the meeting, we'll send this out so everybody has a record of which ones they've offered to carry and identify what remains open. Currently, that is only option 2. I will note that we have pre-filed any legislation for dual introduction. So if there's any piece of legislation that has one patron and you are of the opposite house and are interested in carrying, we can also do dual introduction. This is the closest to having all of our policy options with patrons we've ever come that I can recall. So
No, I want to thank the members. Really appreciate everyone stepping up this morning. Really do. We'll talk about the budget later, but it's good. But it's good to have that. I really appreciate that. Excellent. Okay. Well, great discussion. I think we've got some excellent policy recommendations there. So we're going to pivot right to our transportation-related barriers to healthcare discussion. And we have Emily and family to join us. Thank you, Emily. And Jen, thank you so much. That was excellent. Thank you.
All right. What? Okay, I'll let you. All right. Good morning, Mr. Chair and members of the Commission. This morning, I'll be providing you all with a briefing on our strategies to address transportation-related barriers to healthcare study. The purpose of this study is to describe the types of transportation barriers and the factors that contribute to them, identify and evaluate existing healthcare transportation interventions and programs in Virginia, identify strategies Virginia could implement to address transportation barriers, and recommend policy options to reduce transportation barriers to healthcare for patients in Virginia. The major study questions include what types of transportation barriers to healthcare exist and how do they manifest in Virginia, which populations are most impacted by lack of access to adequate transportation to healthcare, how effective are current healthcare transportation programs that receive state funding, and what policy levers exist at the state level to address transportation barriers to healthcare. JCHC staff found that the Virginia NEMT program has improved in recent years, but data collection could be enhanced. Fixed funding amounts hinder expansion of transportation services for Section 5310 program recipients. Transportation services in Virginia are siloed, and rural areas of Virginia need additional transportation options and resources.
For people listening in, NEMT is non-emergency medical transportation. Acronyms, people may not know what that was. Thank you.
All right. We will begin with an overview of the background of the study. As a reminder, this is a brief background overview to highlight some of the main takeaways from our more extensive background briefing, which was presented at our June Commission meeting. Transportation is a key component of accessing healthcare for patients. Studies show that patients who lack access to transportation are more likely to have increased emergency department visits and hospitalizations, forego needed treatment, have increased medication non-adherence, and in some cases have an increased risk of mortality. A Department of Rail and Public Transportation report found that in 2020, approximately 6% of households in Virginia did not have a vehicle available to them. And the Southwest region had the highest percentage of households living without a vehicle at 7%. They also found that throughout rural Virginia, there are many areas where more than half of the households live without a car. While new modalities of delivering healthcare services such as telehealth may offer some patients the ability to access particular healthcare services, certain treatments and healthcare services still require the in-person presence of both the patient and the provider, such as patients requiring dialysis or patients receiving cancer treatment. For these patients, a lack of transportation can be a significant barrier to care. Availability of transportation does not mean it is truly accessible. The Dimensions of Access framework organizes individual, community, and health system variables influencing healthcare access into 5 interdependent dimensions, which you can see here on the screen. Applying these dimensions to transportation services and understanding how the dimensions intersect with each other can highlight barriers people may face to accessing transportation services. For a transportation service to be truly accessible for patients, it must meet each of these dimensions of access. For example, if a patient is financially eligible for a transportation program, but the program does not serve the area in which the patient lives or receives healthcare services, the patient cannot access the program in a way that is truly meaningful for them. For certain patient populations, lack of access to healthcare transportation has a much higher burden. For example, individuals who require frequent engagement with healthcare, such as elderly patients or persons requiring dialysis, may find additional difficulty around obtaining reliable transportation for recurring medical appointments. Also, individuals with low income or limited resources can face particular burden regarding access to transportation as it relates to cost. Finally, patients who face longer travel distances may find additional burdens related to acquiring proper transportation due to longer travel times. In Virginia, there are 2 transportation programs that provide transportation to healthcare, which were identified by JCHC staff as receiving variable amounts of state funding to those with the highest transportation needs. These programs include the Medicaid Non-Emergency Transportation Program, or NEMT program, through the Department of Medical Assistance Services, and the Enhanced Mobility of Seniors and Individuals with Disabilities, Section 5310 program, through the Department of Rail and Public Transportation. We will now go over the Medicaid Non-Emergency Transportation Program. DMAS is required by federal Medicaid regulations to ensure that members have access to transportation for medical services. This regulation is referred to as the assurance of transportation. And while states are required to assure transportation, there are no stipulations enforced by the federal government around how a state's Medicaid transportation program operates. As a result, non-emergency medical transportation programs vary by state. In most states, the state Medicaid agency contracts with an NEMT broker to coordinate member trip requests with NEMT providers who transport Medicaid enrollees to healthcare services. In Virginia, DMAS has chosen to use a mixed model by hiring a statewide transportation broker for the fee-for-service population and then allowing the managed care organizations to select their own statewide broker for the members that they serve. The fee-for-service NEMT program currently has a contract with ModivCare to serve as the statewide transportation broker. Anthem contracts with Access to Care, while United, Aetna, and Centera contract with ModivCare. JCHC staff analysis of DMAS and MCO data shows that NEMT transportation brokers have improved on-time performance over the past 3 years. The fee-for-service NEMT program requires that NEMT providers meet benchmarks for on-time performance for at least 95% of all rides provided or receive a financial penalty. DMAS does not establish these same standards for MCOs as the MCOs establish their own benchmarks for their brokers. Data indicate that performance can vary between brokers and even varies between MCOs utilizing the same broker. For example, in 2022, ModivCare's on-time performance for Aetna and United were lower than the company's performance for the fee-for-service NEMT population. However, beginning in 2023, ModivCare provided better on-time performance for NEMT services for Aetna and United than with DMAS for the fee-for-service population and Centera. Overall, on-time performance improved for all NEMT programs in Virginia between 2022 and 2024. NEMT brokers have also improved performance related to unfilled trips. Unfilled trips are defined as cases in which an eligible member requests a ride, but the ride is not provided because the broker does not have a transportation provider or vehicle available, or the transportation provider failed to collect the member at the appropriate time. Within its fee-for-service contract, DMAS requires ModivCare to keep the number of unfilled trips at or below a number equal to 0.25% of the total number of trips requested each month. For any month that the number of unfilled trips exceeds this amount, ModivCare is subject to a financial penalty. The rate of unfilled trips improved substantially between 2022 and 2024, with ModivCare reporting that 0.28% of trips were unfilled in 2024 for the fee-for-service program. For MCOs, including Aetna and United, which also use ModivCare, unfilled trips have been below the 0.25% established by DMAS as the benchmark performance for the fee-for-service NEMT program. For all NEMT programs, the unfilled trip rate has decreased over time. JCHC staff also found that client complaints about NEMT services are very low. DMAS requires ModivCare to provide complaint information about fee-for-service NEMT services, and JCHC analysis of complaint data indicates that fee-for-service NEMT clients are satisfied with the transportation services they receive. From July 2022 to March 2025, ModivCare provided almost 6 million trips for members enrolled in the fee-for-service program and received complaints for only 10,000 trips, or 0.17% of trips. Complaint rates for NEMT services provided through the MCOs are similarly low. All 4 MCOs for which data was available report low complaint rates, with rates averaging less than 0.05% of all rides. Previous slides indicate that the NEMT program is performing relatively well. However, MCOs do report that significant number of requests for rides are not completed. Rides not being completed are a different metric than the previously mentioned unfilled ride rate. Rides can be deemed not complete for multiple reasons, including patients requesting rides outside of the required window or patient cancellation. Aetna and Anthem all reported that around 30% of rides requested were not completed for each year of data. Sentara reported lower percentages of ride requests not filled in 2022 and 2023 under their previous broker, Southeast Trans, but had the highest percentage of rides not completed at almost 37% in 2024 after they switched to ModivCare. When JCHC staff inquired about why requested rides were not being completed, MCOs were not able to provide data on the specific reasons for the broker's inability to complete the ride request. Additional data on this metric could improve decision makers' understanding of the success of the Medicaid NEMT program and could help identify areas in which performance could be improved. Currently, DMAS does not outline standards for NEMT brokers in the MCO contracts other than for late or missed trips. However, DMAS does collect performance data for the fee-for-service NEMT program on several metrics, including on-time performance, hospital discharge pickup, same-day non-emergency urgent care transportation, timely recurring medical appointments, timely life-sustaining trips, and unfilled trips. Because DMAS does not specify performance metrics for MCOs to include in contracts with transportation brokers, Virginia's Medicaid MCOs are tracking and collecting performance metrics data differently, making strong comparisons between programs and efforts to understand program quality difficult. As such, the JCHC could direct DMAS to amend contracts with the MCOs to require them to adopt performance metrics for NEMT brokers consistent with performance metrics implemented for the fee-for-service NEMT program. NEMT program prior authorization requirements for trips over a certain length can create barriers to accessing transportation for Medicaid members, particularly those who live in rural areas of Virginia. Prior authorization for trips over a certain length may prevent members who live farther from healthcare services from accessing those services because patients may not be able or willing to navigate the processes required to obtain prior authorization. Neither federal nor state regulations impose prior authorization requirements on NEMT trips for eligible Medicaid members. CMS and Virginia guidance does require that NEMT services be delivered in the most economical and cost-efficient way, but there is no specification for what that means. Some states have made this more clear by defining the mileage amount that triggers a prior authorization requirement. For example, to reduce barriers in rural areas, Nevada removed long-distance verification requirements since they reported that NEMT trips in 90% of rural counties met their minimum 100-mile distance requirement. Stakeholders suggested that MCOs may be implementing stricter limitations than necessary due to a lack of guidance from CMS and DMAS regarding allowable miles that are considered cost-effective. As such, the JCHC could direct DMAS to develop guidance to the MCOs regarding NEMT mileage prior authorization requirements. DMAS should develop a recommended mileage amount for which prior authorization is not allowable. We will now go over the Enhanced Mobility of Seniors and Individuals with Disabilities program, or the Section 5310 program. The Department of Rail and Public Transportation administers Section 5310 funding, which provides federal formula funding to states to enhance mobility for seniors and persons with disabilities. The goal of the program is to improve mobility for seniors and individuals with disabilities by removing barriers to transportation service and expanding transportation mobility options in large urbanized, small urbanized, and rural areas of the state. In Virginia, DRPT administers FTA Section 5310 grants by awarding individual grants to human service transportation providers through an annual grant application process. Any human service transportation provider in Virginia is eligible to apply, and awards are given to allow providers to make capital purchases, assist with operating funding, and perform mobility management services. DRPT reported that Section 5310 program funds in fiscal year 25 totaled over $10 million. For fiscal year 25, there were a total of 34 recipients and 50 projects selected to receive 5310 funding from areas all across the Commonwealth. And projects ranged in cost from around $6,000 all the way up to $850,000. In fiscal year 26, 5310 program funds totaled close to $16 million, and DRPT selected 35 recipients in 52 projects. This increase from fiscal year 25 was due to an increase in both federal and state funds being allocated to the 5310 program. DRPT provided $2.4 million in matching state funds, which included their normal appropriation of $1.5 million, plus additional funds from DRPT's balance of unobligated paratransit funding from prior fiscal years. While DRPT was able to increase funding for operating expenses and capital purchases in fiscal year 26 due to these rollover funds, DRPT cannot sustain heightened levels of allocations above the $1.5 million received each fiscal year without additional appropriations. Fixed funding amounts that do not consider the growing costs of operations hinder the expansion of transportation services. Section 5310 program recipients indicate that the demand for transportation services has intensified. Multiple programs reported that the rising capital costs and costs of program operations without an increase in funding makes it virtually impossible for them to expand services. And the fixed allocation formula for 5310 program funds established in federal rules further limits the funding available for transportation programs in small urban and rural areas of the Commonwealth. Because 60% of all federal funds must be allocated to programs in large urban areas, rural and small urban areas share only 2/3 of what large urban areas receive. Additionally, funds designated for one category of projects cannot be transferred to another category. For example, if a large urban area such as Hampton Roads does not use all of their 5310 program funding, DRPT cannot reallocate the funding to other areas of the Commonwealth. State funding for human service transportation programs serving older Virginians and Virginians with disabilities is provided through the Commonwealth Mass Transit Fund. The General Assembly has designated $1.5 million of the total amount included in the fund for human service transportation programs which serve these two target populations. Historically, this $1.5 million has been used as state matching funds for human service transportation programs funded through the Section 5310 program, which went towards paying the state share of operating expenses. Increasing state funding for human service transportation available through the Commonwealth Mass Transit Fund would give Virginia additional flexibility in operating the Section 5310 program and allow the state to expand available funding through the program. With additional state funds, DRPT would have the flexibility to choose where and what types of human service transportation projects should be funded in Virginia consistent with state needs. As such, the JCHC could introduce a budget amendment to increase the portion of the Commonwealth Mass Transit Fund dedicated to supporting human service transportation programs to 0.0045% of the total amount included in the fund. This change from a fixed dollar amount to a percentage-based amount would allow this funding to increase over time as the fund increases and could eliminate the need for future legislative action to update amounts available to support human service transportation programs. Changing the fund for the Paratransit Fund from $1.5 million to 0.0045% of the fund would increase the amount of funding to just under $2.4 million for fiscal year 27 and just over $2.4 million for fiscal year 28. Braiding federal funds is an opportunity to meet local match requirements for programs. In addition to federal and state funding, agencies are required to have a local match contribution as well. Current FTA rules allow program recipients to use funds from other federal programs to meet local matching requirements. This is called federal fund braiding, and it is allowable if the funding is from a non-U.S. Department of Transportation agency, such as federal Medicaid funding for NEMT. However, Section 5310 program recipients expressed difficulty managing transportation funding from multiple sources, discouraging recipients from seeking additional funding for which they may be eligible. Many Section 5310 program recipients are small nonprofits who feel that they do not have the staff or resources to take on another funding stream and the administrative burdens that might come with it. Lack of capacity to manage multiple funding streams is particularly problematic when grant recipients do not have sufficient state or local funds to meet local match requirements for federal transportation grants. In stakeholder interviews, 5310 recipients expressed an interest in learning more about how to braid federal funds to build program capacity. DRPT could collaborate with other state agencies such as DMAS to provide technical assistance to local transit agencies on how to best capitalize on these opportunities. As such, the JCHC could introduce a budget amendment to add $500,000 per year to the Commonwealth Mass Transit Fund for DRPT to provide technical assistance on program financial management to Section 5310 program recipients, including guidance on braiding of federal funds and how to establish themselves as NEMT providers. We will now go over the regional coordination of transportation services in Virginia. Transportation services in Virginia are mostly siloed, with programs offered by different providers that may or may not communicate with each other, suggesting the need for increased coordination between transportation agencies. In Virginia, the complexity of the siloed transportation system makes it difficult for patients to find appropriate services and frustrated when they have to interpret different eligibility requirements, service areas, and other service guidelines on their own. A solution to this issue is to increase regional coordination of transportation services. Coordinated transportation occurs when multiple transportation agencies work together to deliver transportation services. Coordinating transit services can provide more rides for the same or lower cost, simplify how services are accessed, and improve rider satisfaction with services. Transportation coordination can occur at the agency level. An example of this is regional transportation hubs. Regional transportation hubs are formalized, coordinated initiatives between transit agencies. Transit agencies can share resources, information, and funding, such as passenger trips and vehicles, vehicle purchasing or maintenance, or mobility managers. By participating in these hubs, each transit agency increases its capacity to provide trips, the availability of transportation options for riders, and the efficiency of regional transportation services. Transportation coordination can also occur at the individual level. This is called mobility management. Mobility management programs work with individual clients to provide information about transportation options in their area and coordinate transportation that is most appropriate for the client's needs. Stakeholders identified mobility management as a tool that could benefit Virginians attempting to access transportation services, particularly when patients may be unaware of transportation services in their area or unsure of how to access those services. Expanding regional transportation hubs and mobility management services in Virginia is an opportunity to improve transportation coordination across the Commonwealth. With additional funding, DRPT could support the development of regional transportation hubs and mobility management services. As such, the JCHC could introduce a budget amendment to provide up to $8 million per year for DRPT to establish a competitive grant program for private nonprofit organizations and state or local government agencies to plan, establish, and sustain mobility management services or regional transportation hubs. DRPT stakeholders report that 5 Section 5310 program grantees spend approximately $1 million per year on mobility management activities, including cost of staff members and marketing and supplies. As such, $2 million per year could fund up to 10 mobility management sites, $3 million per year could fund up to 15 sites, and $4 million per year could fund up to 20 sites. 20 sites would include statewide coverage for mobility management and would establish mobility management hubs in each planning district area. If grant recipients were interested in establishing a more comprehensive approach to transportation coordination, they could consider establishing regional transportation hubs in addition to mobility management sites. These hubs would include mobility management, but would be more comprehensive in their approach to regional coordination. DRPT stakeholders report that 5 grantees spend a total of $1.9 million each year on transportation hub services. As such, $4 million per year could fund up to 10 regional transportation hubs, $6 million per year could fund 15 hubs, and $8 million per year could fund 20 hubs. 20 hubs would provide statewide coverage for regional transportation hubs by establishing a hub in each planning district area. We will now go over rural transportation in Virginia. JCHC staff found that rural areas of Virginia need additional transportation options and resources. National data demonstrates that rural residents live an average of 10.5 miles from the nearest hospital, compared to 4.4 miles in urban areas. Also, individuals in urban areas typically have access to some form of public transportation, which is less common in rural areas of Virginia. Stakeholders report that even when public transportation is available in rural areas, it may not serve the entire population. This makes accessing healthcare services difficult for residents of rural communities and places additional burden on human service transportation providers that provide rural clients with demand response transportation services. Microtransit could be a solution to increase transportation to healthcare in rural areas. Microtransit is a demand response transportation service that optimizes its route as riders request rides to provide the most efficient route for picking up and dropping off passengers. Riders request rides through a mobile app or a call center and are picked up by shuttles which carry other microtransit riders within a set service area. Microtransit is more complex than fixed route service because it follows an optimized route that is developed by microtransit technology. However, it is more limited than demand response services because it only provides pickup and drop-off points within the designated service area. Microtransit is particularly effective in rural areas because it connects rural residents to nearby city centers and transportation hubs by bringing them from the outskirts of town to more prominent locations. In Virginia, 2 agencies have successfully implemented microtransit programs. Both agencies serve extremely rural areas of Virginia, and both programs continue to see growth in ridership. A microtransit grant program for rural areas of Virginia could expand transportation services for rural residents. Current grant options for microtransit allow transit agencies to test out new transit services or to develop technology and innovative transportation projects. However, this funding is only available to programs for 1 to 2 years and does not provide an opportunity to build sustainability. A state-funded, long-term sustainable grant program could assist transit agencies with startup funding, as well as funding to build sustainability. A grant program focused exclusively on rural areas of Virginia could also assist in filling federal funding gaps. With a state-funded grant program, DRPT would have oversight of eligibility details, ensuring funding is awarded to agencies serving communities with the highest need. As such, the JCHC could introduce a budget amendment to provide up to $5 million per year to DRPT to establish a competitive grant program to provide funding to localities to plan, establish, and sustain microtransit services in rural areas of Virginia. Program costs estimate that one rural microtransit service zone costs roughly $250,000 to $400,000 per year to operate. DRPT stakeholders indicate that providing $2.5 million per year would fund between 6 to 10 rural microtransit zones per year, while providing $5 million per year would fund between 12 to 20 zones per year. Mr. Chair, public comment on the policy options presented today will be open through November 7th and may be submitted via email or mailed to the JCHC address on the slide. A summary of the comments received will be shared with members at the December meeting when you consider which of the policy options presented today will become JCHC recommendations. Mr. Chair, this concludes my presentation, and I'm happy to take any questions at this time.
I have a question, Mr. Chair.
Emily, thank you so much. I'm going to start with Senator Favola.
Thank you, Mr. Chair.
Okay.
Thank you for your thorough presentation. I am looking at the slide that, I guess it's slide 55 in my packet. It talks about the implementation considerations. I am interpreting this slide to me, this would all be state money that you're suggesting? Okay. So my question, Mr. Chair, is on an earlier slide, we talked about the combination of some local dollars as well. So when we go to the policy options, I think it would be helpful if we could really clarify the local expected commitment to track whatever increase in state dollars.
Absolutely, Mr. Chair, Senator Favola. So all of the numbers that are included here are all state dollars. There's no local funding included in this. So these would be the creation of new programs. The local match that I mentioned was were federal requirements through the 5310 program. So for these would be new programs that might be applicable to 5310 programs, but could maybe be applicable to other agencies as well.
But may not be.
And so there would be no local match requirement for this unless DRPT maybe decided to set that up when they create their plan, because part of the policy option was to ask them to basically create a plan and then bring that plan back to the JCHC next fall to say, hey, this is what the program would look like if we were to set it up. And so potentially as a part of that, we could ask them to look at, local match requirements.
Mr. Chair, I would just, from my perspective, I think it might be a helpful option to have them just, possibly set up a local option possibility. We can decide to act on it or not, or we can, just use state dollars. I'm just cautious with our state money.
Thank you.
You can add that. Senator Hoshman.
Thank you, Mr. Chair, and thank you for the presentation. In taking a look at policy option 4, particularly with the facts that you shared about braiding federal funds, Do we know how much funding is potentially being left on the table because our folks don't have the capacity to navigate all of the systems, and an investment of $500,000 per year might actually be bringing in greater revenue to the Commonwealth?
Yeah, Mr. Chair, Senator Hashmi, that is a very excellent point. I don't have the exact dollar figures on that. I could try and work with DMAS to see if they would have numbers on, like, for example, if a 5310 program recipient decided to become an NEMT provider, what that might look like in terms of like revenue increase for that program. I don't have the exact numbers, but I do know that any amount of funding is helpful for these very small agencies who operate on very small budgets. So, but I can try and work with them and see if that's something they could provide to me before we vote on this option.
Yes, Delegate Sickles.
Yeah, were you able to, did you talk to, you might have mentioned this, I apologize if I missed it, but did you talk to Motive Care about their experience in, they're in bankruptcy, so maybe they might have some advice for us?
Mr. Chair, I'm happy to answer that. We are watching that situation and continuing to collect information, and I expect we will be providing sort of a follow-up for you on what's going on there after this meeting. We can provide a follow-up memo to explain the situation and see if there is any relevant information.
So, Mr. Chair, Delegate Sickles, as of right now, the only information that we had was that services are not going to be interrupted at the patient level, that this was purely a company level change that they were doing with filing for bankruptcy, and that there should be no impacts at, like, for individual patients on receiving services.
How about suggestions that they might have on how to make this program work better?
Yeah, Mr. Chair, Delegate Sickles, we can certainly reach out to them and, yeah.
Thank you.
Mr. Chair?
Yes, Delegate Waxman.
Yeah, thank you, Mr. Chair. I've got a question. Has there been any effort to do like a map of the state to find out what areas may be less served than other areas?
Mr. Chair, Delegate Waxman, that's a good question. I believe that DRPT, in one of the reports that I reviewed, they did, and I can send the report to you if you're interested, they did have heat maps where they looked at where transportation services were offered versus like population size and things of that nature. But I think that was only for like public transportation options. I don't believe that included anything with, like, for example, the demand response programs or the human service transportation programs that I was referring to. I'd have to go back and look at that, but I do believe that there were some heat maps that I could share with you that showed that sort of where some of the gaps are.
Thank you. I appreciate that. And if I could add, Mr. Chair, last year when we did the Rural Special Select Committee, I think everywhere we went to, we asked what people's barriers were to health care, and transportation was at the top on just about every one. I remember one story particularly, I think we're at the hospital in Ridgelands, and they mentioned that they had somebody with the need to get some special oncology services at a facility in Roanoke. And to get them from Ridgelands to Roanoke, an Uber came down from Richmond, dropped the patient off at the hospital in Roanoke, and then the Uber left, and they had a hard time getting that patient back home. Yeah. Thank you.
No, just to elaborate what Delegate Waxman was saying, uniformly as we toured the state, we heard in the rural areas just incredible challenges, and I know you focused specifically on the rural health, the impediments there. It's 10 miles in Richmond is not 10 miles in Richmond. It's a very different thing, and 10 miles could be an hour if you have a vehicle to get over those mountains. So it's a big challenge. I was intrigued, Emily, and I think the report, I actually opened the report up, on the microtransit is just sort of order of magnitude what we're looking at there. And the couple that you do describe a couple of programs that have been successful. It seems like a pretty modest expenditure has had a significant impact there in terms of what they're doing. And tell me, again, I'm reading the description here, but just visualizing this, this is literally a van that is developing a route based on request.
Absolutely.
And they're going A to B to C to get people. Am I saying that right?
Yeah, Mr. Chair. So yes, you're understanding that appropriately. So essentially how it works is individuals either through an app or a call center, they will request a ride and request a drop off. And what the microtransit technology does is as people are requesting rides and drops offs, it's optimizing its route around town to have the most streamlined, like the quickest route in order to get individuals to be picked up and dropped off. So it's a little bit better than just, the traditional fixed route, because fixed route, you have specific bus stops that may or may not be located close to drop-off points or pickup points, but this would actually be picking individuals up from, potentially their homes or other businesses around the area, and then bringing them to different areas. And it is, as you said, like a shuttle, so it's a shared ride service where you may have 5, 6, 10 individuals who are all on the bus and getting dropped off at these different areas.
Great. Douglas Hodges.
Thank you, Mr. Chairman. Thank you for the presentation. Learned quite a bit. When you looked at rural and defining rural, did you look at rural or kind of the mixed rural areas too? Because 10.5 miles seems like a very short distance compared to what I think is rural.
So, Mr. Chair, Delegate Hodges, that's a good question. When we were looking at rural, I think we were looking I think that statistic, I'm not sure, I'd have to go back and look exactly on how they were defining rural. At least for this study, we were looking at the federal guidelines, FTA guidelines for what's considered rural, but also taking into consideration that, there are some areas, for example, Roanoke, where there's very rural area outskirts, but then there's also Roanoke City, and so we did accommodate for some of that as well. Yeah.
Okay, and to follow up, Mr. Chairman. Thank you, and thank you for the comments, Delegate Waxman and yourself regarding access in our rural areas, because we're looking at pharmacy deserts, we're looking at doctor deserts, we're looking at transportation deserts. And when you looked at this, you mentioned public transportation and those gaps. Did you look at the nonprofits that are providing services? Because I know I look in to follow up on Senator Favola's comments. We have something very successful in our area, but it's a combination of federal funds, state funds, and local investment. Yeah. So do we need to look at those types of projects where we can bring in the localities, we can bring in the states, and we can bring in the feds to make those more successful?
Yeah, Mr. Chair, Delegate Hodges. Yes, so I believe you're referring to Bay Transit. Yes, so we interviewed them, we spoke with them about all the great work that they're doing in the Northern Neck area. And yeah, so yes, we did speak with those nonprofits. They're actually a 5310 grant recipient. They also, I believe, received 5311 program funds. So they're a really great example of being able to utilize multiple different funding streams and try and capitalize on that in a very rural, more limited area. Yeah.
Emily, thank you again. And I think just to echo some of the things you shared, it was so say discouraging, so impactful when we had these conversations with the folks, because you picture these rural areas, and first of all, do you have a place even for people to go? In some cases you do, maybe a free clinic, an FQHC, or an actual hospital. But then what we heard from the providers and from the systems, and then from the operators of these clinics, was that we just can't get the people in the door. So they've checked some of the boxes, which is they've got a facility, and I hope they keep those facilities open. That's another challenge. They've got providers there, which is also a challenge, getting the providers. But then if you can't get the people there, and particularly for follow-up appointments or prenatal care, I think that's what we really heard, because then you're talking about, prenatal care, what that's like. That's a very frequent visit. It's a very important set of visits. And when folks are facing the multi-hour challenge, they're just foregoing, and that's absolutely the wrong direction, because that's the front end, or can be the preventative care that we're so much trying to implement. So really appreciate this. We'll look forward to formalizing this. I will note that Delegate Sickles carried an amendment for a transportation pilot to work with the free clinic system and trying to get folks to the free clinics. I think we'd love to hear how that's going. I think it's still getting off the ground, but I know that's a direct service to get folks into a few targeted free clinics, and hopefully that's going to work, and hopefully that's a model we can leverage.
Yeah, absolutely.
Great. Any other questions? Emily, thank you very much. We have one more thing to do before we wrap up here, and I'm going to bring Sarah back up. So prior to this meeting, we had just an excellent discussion with the Executive Committee looking at our 2026 work plan. I think everyone here knows we do not lack for excellent topics, and I really appreciate everyone's suggestions for those. It is truly the toughest job that we have here is trying to narrow down that list of topics into a work plan. We've got to respect the staff's time. We have an amazing staff, but they have limited time. And so we've gone through that, I think, come up with a really good group of recommendations. And Sarah's going to walk us through that and then the time frame for how we look at these things. And again, Sarah, I appreciate you and the staff, all you did to put that together.
Well, thank you, and we'll be quick because it's the end of the meeting, and we don't want to stand between you and that. So very briefly, there's a slide. There it is. Some of you have seen this several times today already. So quick reminder of our work planning process. We establish a work plan in the fall that is essentially projects for the first half of the next year, and then you will have a second chance in the spring to review the work plan you adopt this fall to make changes or make additions to that work plan to accommodate new policy priorities or take on additional projects. So that is where we are at. We met this morning. The executive subcommittee selected 4 topics for the first half of 2026. And I say first half of 2026 because we are taking a slightly different approach this year. Rather than simply adding comprehensive studies that will take a full year to complete, this year we will add all 4 topics to the work plan as information briefs, which are essentially the background half of a comprehensive study. That approach will allow us to dig into background information about each of the 4 topics I will explain, provide context, provide a deeper understanding of the nature of the problem and the conditions that contribute to the existence of that problem, so that in the spring, when we brief that to you, you can decide where you would like to target work for policy option development over the course of the summer and into the fall, or have the flexibility to adjust the work plan to take on any new priorities you may have or new projects you would like us to pursue. So I don't have a slide because there was not time between the 2 meetings, but the 4 topics that the executive subcommittee adopted are, first of all, an overview of Medicaid program changes resulting from H.R. 1, what we know about the policy changes, the implementation timelines, and any information we have about the anticipated impacts. The second option is a look at the financial condition of rural hospitals in Virginia and the factors that are contributing, impacting the financial condition of rural hospitals in Virginia. That is sort of a companion to the first piece. So we'll provide information on what those factors are and identify some areas for policy option development should you choose to move forward with that. The third item, work plan project, is a look at the role of assisted living facilities in the continuum of long-term care services and facilities in Virginia to understand the role of ALFs, rules applicable to ALFs currently, changing trends in demand for availability of and access to ALFs, and any gaps in services that we may want to address in that area. The last work plan item is a look at the public health impacts of e-cigarette use and e-cigarette retailers in Virginia, including applicable regulatory requirements, the types of products sold, and trends in the number and location of retailers to understand the individual and public health impacts of those decisions. So those are the 4 items. All 4 were added to the work plan or proposed to be added to the work plan as information briefs, meaning we will be providing the results of that preliminary work to you at our May and June meetings. At that time, you'll have the opportunity to decide if you would like to pursue policy options on any of those items or if you'd like to adjust our work plan. So,
Questions?
Those are the options.
Yes, Senator Favola.
Thank you. On the cigarette retailers, you're going to get into the vaping shops?
Yes,
it
these are vape
seems to
shops.
be a very common problem. So that is included under that study. Okay.
Mr. Chair, yes, those will be the vape shops to understand trends in location, density, applicable regulatory requirements, and to get a clearer picture of the situation in that context
I appreciate
and the impacts.
that. Thank you.
Thank you for the question, that clarification, certainly impacting all of us across the state. And then just a little bit more color on the Medicaid look. It is the elephant in the room. We know major changes are already happening with that. We had a number of recommendations from members that sort of all tie back to Medicaid. So we thought at least we'll start getting our legs under so that see we're going to be just order of magnitude what we're dealing with. What are the changes? What are the timelines? Obviously, the budget impact, the biggest question there. So that's certainly going to be a work in progress, and I'm sure we'll have to adjust as we go on that as we learn more. And talked about rural hospitals, and then of course the assisted living facilities. A lot of us hear from a lot of our constituents who are in those facilities, or family members who have loved ones there, and a lot of questions. And so we've sort of combined several things into a look there. I think that's super timely. Other questions on the work plan?
And Mr. Chair, the next steps are that we would ask you to vote today to sort of adopt those as our work plan items. Then staff will start preparing study plans on each of these as we have the capacity as these this year's projects are coming to an end. We will present those those study plans to you in December at our meeting at that time. And like I said, as we have capacity over the next few weeks, we'll start working on these priorities in anticipation of the spring.
Excellent. I'll entertain a motion then to approve the work plan.
So moved. Second.
Have a motion and a second. Any further questions on it? Otherwise, all in favor? Aye. Any opposed? Okay, we are good.
Thank you, Mr. Chair.
Great, thank you. Members, again, I really appreciate your work today. Great progress and a lot on our plate, but we have an expert staff here. They've made so much progress, and I really thank them for all their good work. And with that, we are adjourned. Thank you.